medical view and personal view are better if the patient still on the left. In intensive care, most of the patients are maybe anesthetized and they are supine. Is there a modified view to show chambers?
It's not always possible to move the patients, but if we can, sometimes we do try to, the nurses are turning the patients regularly in the intensive care unit, so if we could coordinate our exam when their right side is being moved up and they're moved over so they're somewhat lateral, that can be helpful. Another thing for the ICU doctors versus a cardiologist, we always place the equipment on the patient's left side of the bed, and we stand on the right side using our right hand. I notice the cardiologists are always on the same side of the bed. It seems to function better for us, and oftentimes we might be doing a procedure, so we can have both hands and then the instrumentation's on the other side. But I don't know if that really answers your question.
Basic difference between PPM and prosthetic valve obstruction. Yes, sir.
As I said, in the PPM, you have to check the index effective orifice area. So you calculate the effective orifice area on the echo and divide body surface area. You get an index Q is less. So, but you have to rule out at the same time there's no structural defect of the valves. You have to do the DVI, which all are normal. If there is a low ES state, whether you won't get approximate numbers, then you have to do a stress input. You still see the IO is only reducing the PPM. The rest of the rest of the things is normal. If everything is normal, like structural defects are abnormal, the DVI is really abnormal, then all that won't favor us. Apart from that, PPM is sets early. So the first recommend the bypass, after bypass when you come to know the index to orifice area less, and all it will show in all the subsequent exams. Whereas the late onset, the structural defect will come later. That is why you have to store the data of each successive exam so that it's available for comparison. Also, the PPL is present in all the exams. It cannot be, it was not there before and then it suddenly disappears. So it has to be tested. Whereas the structural defect will
but DVI also decreases during the option.
in structure, intrinsic risk.
Just for the previous question about transthoracic echo in supine or like in an ICU setup, in addition to what James has already alluded to, is I tend to actually angle the probe as if you're seeing the tricuspid, left lateral. So in the supine, you just have to angle it further out, and assume it like a torch. You'll see what you want to, shine it where you want to. So I tend to actually for parasol longus, something to get angle a bit more further out, and people with chest strains, and these are the post-cardiac and some of the others, you go a bit more laterally here, and then you look up. These are some of the things that would help out.
One of the logistics matter I didn't mention, I usually do mention, is that it's really practical on a busy ICU service to if you find one patient, you want to use the ultrasound and then go run and get it. So I think it's really important to take the ultrasound equipment with you on rounds every day. And then I have two different rules. One is that the ultrasound transducer touches every patient in some way every day. So each patient has to have the ultrasound transducer hit their body somewhere, or we don't leave the room. Okay, so that's one rule. Or the other one was you must make a prediction before you go in the room. Is the patient wet or dry? Does the patient have good cardiac output? Make those predictions outside the room, and then go in and do the ultrasound, and then see if you make a change and keep track and actually write those down. So those help me on rounds to make sure that we're doing it, and you might facilitate starting a program in your intensive care unit.
So which is the best view for the tamponade patient? For the tamponade? A bical or subcostal?
Which is the best view for tamponade?
I think the best one that we use is the subcostal. And we look for the McCullen sign and the diastolic compression of the right ventricle and the atrium. Those are important findings because that shows that there's a physiologic effect of the fluid that's in the pericardial space.
James can answer The last question. So, what we are doing here is it's point of care ultrasound. There is no best view. You are looking for yes or no binary answers. Whatever gets you the information is the best view. There will be the patients with lots of brains. You cannot position patients. Sometimes you can get what you need by unconventional views. So don't restrict yourself to like the conventional views that you see. In the ICU, in the operating room, things are different. What is described in the textbooks is for outpatient cardiology. So just keep that in mind. And you're not doing a comprehensive exam. It's just point of care. As soon as you get the information, you just move on.
So I have one last question. What is the status of the IVC collapsibility index right now? There are several papers which are questioning that. Because the technical
IVC index collapsibility index.
So, like, how do you use it in practice?
I've heard about the controversies. I know that there's, in ICU care, everything swings, the pendulum swings. Are we supposed to keep the sugar too tight? No, not too tight. Are we supposed to use the pulmonary catheter? No, we don't. And I'm still in the camp where if I see a plump, 2 centimeter non-compressible vena cava, I'm happy the patient's got a lot of fluid and we don't need to give too much more. But my boss would remind me that even though it shows it's plump and the patient's tanking, he'll say, would you please give some fluid anyway? So you really have to, it's a heads up ball game in taking care of these patients. So I think the leg raise is something I think that helps. You can give that fluid and then you can just put the legs down right away and see if it did any good. But, I haven't quite moved up forward from, I still feel very strongly that helped. There was a physician here last year who had a particular index based on body mass or BMI or the surface area and said that the size, dimension of the inferior vena cava should be calculated depending on those dimensions. So I think that we could refine it based on patient size.
Dr. James, one last question. Many a times we come across occasions where patient is post-cardiac surgery and on transthoracic echo we are getting poor or limited echo windows. So which view you recommend so that we get a brief idea about the patient's LV and RV function?
Well, you just heard it from our colleague. The best view is the one you can get. Our patients in America are oftentimes very obese, and although I do like the subcostal view, sometimes I just can't get it because I can't get the probe to come below the costal margin on these patients. In terms of the dressings, if there's a median sternotomy dressing and then there are chest tubes, I think it was offered that perhaps a lateral view might be the apical 4-chamber or 5-chamber view might be what you can get. It's a possibility. Or, and I know in intensive care, some places their patients will just have a transesophageal echo in place and they'll leave it in place for a long time, and some of them are disposable, so that would solve your problem.
Thank you, sir.
She's saying last question, but can I ask one last question? If you permit. Yeah. Do you look at the diaphragmatic thickness and excursion in ICU patient? Do you think they're useful parameter? What's your experience?
There is a literature there. It's supposed to be 25 millimeters, but I used to use it a lot in our patients. I'd sit them up, and years ago we used to have a lot of patients who had cabs and they didn't have a hemothorax, and they'd ask us to line them all up and do thoracentesis, and so I'd tap them all out and I could notice the excursion very easily, but I have not used that. I suspect that it might be helpful. I think there is literature on that. Yep, I should be looking at it. Yep.
Thank you, Dr. James and Dr. Niranjan. I think we'll move on to the next session.